Well, thanks very much. Stefan actually covered a great deal of what I'm going to talk about because it's all involved with the really getting access going antegrade, and that's when there's proximal cap ambiguity. These are my, there you go. These are my disclosures. In terms of full disclosures, I have to admit that these slides are actually stolen from Manos Prolakis, and any mistakes are his. That's most of my humor with this one. The proximal cap ambiguity is probably, to my mind, the most difficult thing to overcome in CTO PCI. If you know where to go, a lot of us can get there. We've got great techniques to re-enter and whatnot, but if you can't get started, you ain't gonna finish the race. And the Progress CTO registry found that proximal cap ambiguity was one of the most important predictors of failure for CTO PCI. And it's also one of the first things you look at in the hybrid algorithm. And this was realized, 10 years ago, in essence, was that proximal cap ambiguity is one of the things that would make you think about using retrograde access or retrograde techniques initially. So that's the number one thing that you look at is there proximal cap ambiguity? If there is, you need to think about how best to approach this. So this is an algorithm actually that Manos worked up about having an ambiguous proximal cap. And again, this is always the source of this is multiple expert consensi. I'm not going to talk about how to deal with this retrograde. You can either go retrograde crossing with a wire escalation retrograde, which is a nice way to handle it, but often is not successful in these cases, or just using it as a marker, and that's fairly self-explanatory. And the retrograde is a topic for another time. But perhaps one of the most important things that we don't think about is to do a better angiogram. And this is a nice example of this. This is an LAD CTO, and the right coronary artery here. That was a pullback on that showed, and it hadn't shown this on the previous diagnostic study, that there was actually a very good collateral coming back from over the conus branch. And the operator, who is the CTO operator, said, if there isn't a collateral, it's not because there isn't a collateral, it's because I haven't found the collateral. If the tissue is alive, the vessel's there. It has to be getting blood somehow. So in essence, then the LAD was found, and the IM catheter was used predominantly for visualization in this situation. And if you look at it in another view, then you can see very nicely where the proximal cap is located. In this case, scratch and go was done, which Stefan has mentioned. We'll talk a little bit more about in the future. That got it started. You could clearly not in the lumen here. It's got a knuckle on the end of the wire. Stingray wire comes out. The Stingray itself goes through and is able to be, with a stick and swap of the Pilot 200, the distal vessel was wired, and the LAD was able to be successfully stented with a very nice angiographic result. IVUS use is of a great deal of importance, and I've resisted over the years using IVUS and found that was hampering my practice and my patients, and now I use it quite a great deal. The idea in these cases is that when you've got a chronic total occlusion, as everybody knows, it generally closes off to the point of a major branch, and that's where the ambiguous cap generally is. You can't see where that comes off, a lot of times because there's overlap from the vessel there. If you use an IVUS catheter, you can often find the proximal cap and then use that to direct your subsequent wiring. It's important to use a short tip IVUS rather than a long tip IVUS so that you can get as close as you can to the proximal cap. This is a large OM CTO, filling well B collaterals, but the proximal cap is ambiguous. Again, you can see it's filling somewhat here retrograde from the right coronary artery. Dual injection shows you the course of the vessel nicely, but it still doesn't elucidate the proximal cap. A microcatheter was used and just tried to scratch and find. Sometimes you can get a little purchase, and if it's going in very clearly the right direction, you're safe to go ahead with the wire. In this case, that wasn't happening. It just bounced off or slid off. So this is an IVUS out through that distal circumflex coming back, and you'll see coming in at 2 or 3 o'clock there is that occluded obtuse marginal vessel, obviously filled with plaque. That was attempted to be wired. Initially, that was unsuccessful. You'll see the wire coming in here at about 1 o'clock. It's going, but was unable to locate the true lumen, but with redirectioning in a very pointy wire, a Hornet 14. The proximal cap was able to be pierced, and here you can see the wire now clearly in the vessel, which shows you how to get started. The wire was able to be moved forward. A Stingray was brought in. The Stingray wire went out and came through, so a stick and swap was done with the Pilot 200. And this was the final result. There have been reports of even transvenous IVUS-guided CTO PCI, really only useful for the circumflex. I have not done this, but just for completeness, that was showed. The more important things to understand and to be able to do is the techniques actually of moving the cap. And there are a couple of these. Number one is scratch and go, as Stefan already pointed out, where a wire is used to get started somewhere in the plaque up there. Generally, it's a very high penetration power wire. You get it going just a little bit, bring your microcatheter in there, and then use a softer, more knuckleable wire that will then be able to advance and knuckle past the lesion. This is an example of this here, right coronary artery. Very unclear proximal cap. Retrograde was actually attempted initially and was unsuccessful in getting downstream. Antegrade was taken, but the wire was clearly going off course here. Again, even in an extreme lateral view, no clear takeoff for the proximal cap was found. This is an AL guide, AL 0.75 guide, and a Confianza Pro 12 was used to create an initial dissection. Then that was replaced with the JR. The catheter was anchored subsequently for better manipulation, and a knuckle was able to be used to knuckle down to the distal cap. It's more like a base. And the right coronary artery was successful. The next technique is base, which is balloon-assisted subintimal entry, very similar. If you can't get purchase with the wire, a lot of times this is necessary if the vessel's bigger and you can't get the wire to penetrate into the wall. A lot of times you won't use a CTO bend on this, or you will, I'll rephrase that, you'll use a very small CTO bend to start, and then you'll put a secondary bend in order to reach the vessel. You don't want to be in the middle of the vessel. You actually want to be into the side of the vessel. Again, the balloon is used to create dissections. The wire is advanced into that, the microcatheter beyond that, and then a knuckle wire taken distally. This is an example here from Minvo of this. You can see the initial ballooning up there, the wire being able to be advanced then with a knuckle, and subsequently was successful. The last technique really for moving the cap is the Carlino, and the modified Carlino is something that not a lot of operators use on a regular basis. I think of this as sort of an early version of the investment procedure because you create a hydraulic dissection. The original description was to use a very forceful injection through the microcatheter of several cc's of contrast. This creates basically a star type of situation, which can then be used to access the true lumen distally. Now it's used with a much smaller amount of contrast injected into the lesion. A lot of times that contrast will find a way to go into the true lumen, or at least get you started so that you can knuckle down further safely and then use your reentry techniques. So thanks very much.